In this video, we will start our discussion on third stage labor and atonic PPH. So what is this? Let us start. So first we need to see that postpartum hemorrhage is the most common cause of maternal mortality in India. So PPH, most common cause of maternal mortality. Okay, so PPH can be prevented by proper management of third stage of labor. So that's why we're discussing here. In third stage of labor, we need to prevent PPH by proper management. Okay. So management of third stage of labor. So let us see how to manage it. The first main event to manage is placental delivery. So placental delivery is the main event to manage. So in that placental delivery also there is an expected or passive management and an active management. So let us see what is passive management first. Okay, passive management is we will do nothing and wait for the placenta to be expelled out. So the time taken for this is 10 to 15 minutes. There is increased blood loss here, and there is increased chances of PPH and also increased chances of maternal mortality. Of course, PPH and maternal mortality are directly proportional. So if increased chance of PPH, increased chance of maternal mortality, here you will do nothing, just you will see that in 10 to 15 minutes how much of placenta is expelling out. But what you are going to do in active management, so this is called as tussle, that is active management of third stage labor. So here the time taken is 5 to 10 minutes. So just you can see it's a very quick process. There it is 10 to 15 minutes because you are waiting for the placenta to come out. But here just 5 to 10 minutes process. It decrease. There is decreased blood loss here. So decreased PPH here. So there is decreased maternal mortality. So this is preferred. Okay. So active management is preferred. And note that the third stage of labor is said to have prolonged. When you will say that the third stage labor is prolonged, you will say it is prolonged if it is greater than or equal to 30 minutes. Okay, so normally as we said in this placental time will be just 5 to 10 minutes you need to do it, that is active management. But if it is prolonged, you will say it is like prolonged for 30 minutes, then it is known as prolonged third stage or retained placenta. Okay, the line of separation of placenta is along zona spongiosa. So this is one liner. Line of separation of placenta is along zona spongiosa. So along spongiosa layer you will separate the placenta. And the most common method of placental separation, is Skulls method. The main factor which is responsible for separation of placenta is of course uterine contractions. Okay, and the living ligature. What is this? The living ligature is a middle layer of myometrium. Actually this will act like a ligature and it will prevent the blood loss. Okay, so living ligature is middle layer of myometrium. Now let us see a drug called as Dinoprostone. So what is this Dinoprostone? It is a prostaglandin E2. It doesn't prevent PPH. This is very important. So postpartum hemorrhage is not prevented by dinoprostone. Remember that it is a stone, but dinoprostone without E, dinoprostone, is preventing PPH, but dinoprostone, stone, will not prevent the PPH. Remember like that. Now let us see the blood loss after delivery. So after delivery, how much blood is lost? By means of normal vaginal delivery, there is like about less than 500 ml of blood is lost, normal vaginal delivery. But if you see in the C-section, there is like about less than 1000 ml of blood is lost. But coming to cesarean section, that is especially if you do hysterectomy, there is more loss. So more bigger the procedure, the more blood is lost. Less than 1500 ml of blood is lost. So normal vaginal delivery, 500 ml of blood is lost. In C-section, 1000 ml of blood is lost. And even in the, remember that not in C-section, and even in the twin delivery also more than 1000 ml of blood is lost. In cesarean hysterectomy, less than 1500 ml of blood is lost. Now coming to the signs of placental separation, that is gush of blood. If the gush of blood is there, it is a sign for placental separation. And if there is suprapubic bulge is also a sign of placental separation. And height of uterus rises slightly. If the height of uterus rises slightly, and placenta when it is felt in the vagina, okay, and when there is apparent lengthening of cord. In all these conditions, it is permanent, okay. So in all these conditions, this is a sign for the placental separation. So what is the best sign among all this? What you will say the best sign for placental separation? The best sign is placenta felt in vagina. This one is the first best sign. And the second best sign is apparent lengthening of cord. This is the second best sign, okay. So now coming to AMTSL. AMTSL means best method to prevent PPH. So what is the best method to prevent postpartum hemorrhage? That is AMTSL. We already discussed here, that's why I put tick mark, okay. So now let us see what are the process which we do in this AMTSL. So the first one is you give injection of uterotonic agent, okay. So after delivery of baby, you'll give uterotonic agent. And the second thing you do is delay cord clamping, okay. And the third thing which you do is delivery of placenta by control cord traction, or you will do modified Brand Andrew method. And the fourth thing which you do is intermittent assessment of uterine tube, that is early uterine massage. And among the 4 steps, the first step is most important step, that is the injection of uterotonic. This is the most important step. And early cord clamping is never a part of AMTS. You see, it is a delay cord clamping. So early cord clamping is never a part of AMTSL. So this is very important. Now coming to injection of uterotonic. As we discussed the first one, the first injection of uterotonic agent is nothing but oxytocin. So oxytocin is recommended by WHO as a first line drug for AMTSL or prevention of PPH. So dosage of oxytocin which you give is like about 10 international units, and the route is by IV infusion or intramuscular. The onset of action is 3 minutes by intramuscular route, 1 minute by intravenous route. Duration of action is 3 hours for intramuscular route and 1 hour for intravenous infusion. So oxytocin, remember, it is never given as IV bolus because it can lead to hypotension, erythema and cardiac arrest. So let me write it down this. IV bolus oxytocin lead to hypotension, erythema and cardiac arrest. So we will never give it IV bowl, but we'll give IV and intramuscular. So what is the mechanism of action? Actually, it will influx the calcium and release of prostaglandin F2 alpha from the deciduum. So what is the T half of oxytocin? The T half of oxytocin is 3 to 5 minutes. Oxytocin is synthesized by paraventricular nucleus of hypothalamus. The natural oxytocin is a non-peptide Synthetic oxytocin is an octapeptide. This is very important. Now coming to contractions due to oxytocin are similar to physiological contractions, hence they can be used to augment the labor. Okay, so if oxytocin is not available, then WHO recommends this other kinds of drugs, like you can take methyl ergometrin, or you can use the ergo derivatives, which will lead to tetanic contractions in the uterus, but it is not useful for augmenting labor. Okay, it is phototoxic, hence available in brown colored ampules, and the contraindications is after delivery of first twin you should not use, after organic heart disease you should not use, after preeclampsia don't use, after eclampsia don't use, after RH incompatibility don't use. It is increasing the BP, hence never given as IV bolus. So the next drug which you can be used other than oxytocin is Synthomedrine. So Synthomedrine is a fixed dose combination of oxytocin 5 units and methyl ergometrin 0.5 milligrams. Okay, and the next drug is Carb Bactosin. So Carb Bactosin is a synthetic oxytocin. It is an octapeptide. It is having longer T half, and the doses you should give 100 micrograms intravenously over 1 minute. Next, coming to Mesoprost. So Mesoprost is PGEI. Dose is 600 micrograms orally. Side effect, you have fevers, chills, dose dependent side effect. Okay, and it is not contraindicated in asthmatics, but remember it is contraindicated in the case of previous C-section patient. Now coming to another drug that which can be used instead of oxytocin is Carboprost, also called as Dinoprost. Okay, so this is 15 methyl PGF 2 alpha. The dose is 250 micrograms intramuscularly. It is contraindicated in asthmatics. Now coming to the sixth drug which can be used is injection of tranexamic acid. Injection of tranexamic acid, it is a delayed cord clamping. Delayed cord clamping means clamping cord greater than or equal to 1 minute. The range is from 1 to 3 minutes. It is preferred because approximately 80 ml of blood goes to the newborn, which is sufficient to prevent the neonatal anemia. So the conditions where early cord clamping is done is birth asphyxia, need of any neonatal resuscitation, if baby is diagnosed with heart disease, or Rh negative pregnancies. And note that in HIV positive female, and NACO recommends delayed cord clamping, WHO recommends early cord clamping. So delivery of placenta by controlled contraction or modified brand Andrews technique. Make sure that the placenta has separated before doing this step. Complications is uterine inversion. So intermittent assessment of uterine tone. Earlier this step used to be uterine massage. So now coming to PPH, postpartum hemorrhage. So postpartum hemorrhage is defined as excessive blood loss immediately after delivery or until 12 weeks after delivery. Okay, so according to latest definition, irrespective of route of delivery, the blood loss is greater than 1000 ml, it is considered as PPH. So clinical definition is PPH is defined as any blood loss which lead to signs of hypervolemic shock. So practical definition is PPH means drop in hematocrit greater than 10%. So different types of PPH: primary PPH, it is within 24 hours of delivery, most common cause atonic uterus. Secondary uterus means PPH occurring after 24 hours of delivery but within 12 weeks of delivery. Most common cause is retained placental tissue. So what are the causes of PPH? Decreased tone of uterus, most common cause. Trauma, cervical tear, most common. Vaginal hematoma, uterine rupture. Retained placental tissue and decrease in thrombin, that is bleeding disorder. So finally coming to the risk factors of PPH. So there are maternal factors, labor related risk factors, and placental factors. Maternal factors are multiparity, anemia, malnourishment, APH in present pregnancy, PIH in present pregnancy, previous history of PPH, over-distended uterus, twins, diabetes, polyhydramnios, fibroid uterus. Labor related risk factors: precipitate labor less than 3 hours, prolonged labor, instrumental delivery, C-section, injudicious use of oxytocin or sedatives, malpresentation. Coming to placental factors: retained placenta, placenta previa, placenta accreta, placenta subcenturiata. So recent studies have shown that nulliparity can also lead to PPH. So shock index, finally this one, I'm saying it all orally because this video will get so prolonged. Okay, so shock index is equal to heart rate into systolic blood pressure. So the normal shock index is between 0.5 to 0.7. Normal shock index during pregnancy is 0.6 to 0.8. So if the shock index is greater than 0.9 to 1.1, then it's an indication for blood transfusion. So blood transfusion may lead to DIC. Hence always give fresh frozen plasma with blood transfusion. So by this we completed part 1. Next we'll discuss part 2 in another video.